Hi everybody, Dr. Sloan. Going to talk about Neuro Part 2. This is headaches, seizures, and meningitis. Sounds like Lacey's going to help me with this lecture as well. So these are your learning objectives. Make sure that you do know these, that you know what an aura is, that you know what the Brudzinski sign is. It's very clearly labeled in this lecture. That you know what osmophobia, phonophobia, photophobia are, postictal, prodromal. Those are important terms that are used in the care of these patients. And if you are working, with patients that have these kinds of problems, you're going to want to be able to talk intelligently about it. Also, you think most of the learning objectives are pretty straightforward. So management of headaches, and I think the note says it well, but this is really about headaches that are just headaches, not headaches related to something else. Sometimes we just get headaches, and there are reasons for them, but in and of themselves, they're usually, not a sign of anything super serious. However, they can be very bothersome. So, common locations of headache pain. For a tension headache, this is often like a band around your head. You may feel it down the back of your neck, kind of at the base of your skull, back of your neck, down into your shoulders. You feel tight, tense, and it is painful. You can also have cluster headaches. Cluster headaches tend to be more on one side than the other and tend to be around the eyes, ears, cheek area, which is kind of an interesting manifestation. And then there's migraines. Migraines can show up in a lot of places, but many people often get migraines and they'll start just on one side of the head. They may eventually, though, move to the other side as well. So here's sort of the difference between cluster headaches and tension type headaches. And on the left, what you see is sort of a, criteria like what's the age of onset, what gender's affected. So again, I think this is pretty straightforward. If you look at cluster headaches, they're actually quite different than tension type headaches. So cluster headaches tend to be more common in males, no family history of headache. There's rapid onset, clusters in time. This is why they're called cluster headaches, because they come together. You have a headache, and it's there for a bit, and then it goes away, and then it'll come back. You could have multiple cluster headaches in a day. Tends to hit around the orbit of the eye, your temple area, your cheek, and can cause lacrimation, rhinorrhea, and Horner syndrome. I forgot what Horner syndrome is, but I'll let you know by the end of the lecture. Tension headaches, young adult, middle age, not gender specific. The onset is usually slow, but it could be rapid if it's sort of been, the end of a long day and you've been able to kind of stave off a headache, and then it happens to come on pretty quickly. The location is variable and, again, pretty easily treated. More information about that. Clusters occurring in a series. So, set of headaches, goes away, comes back, goes away, comes back. People can have remissions and exacerbations, meaning that they may go for a period of time where they don't have cluster headaches, and then times where they have a lot of cluster headaches. The triggers are really similar to migraines. pathophysiology unclear, and treatment is prevention with medication and avoidance of triggers. If they're really bad, you can do oxygen, sumatriptan, or inhaled ergotamine. We're going to talk about a couple of those drugs. Tension headaches, usually this dull band of pain around the entire head. Onset occurs during times of stress. You can have it for hours. You could have it for days. So if you're unable to really get good rest and kind of break that headache cycle, you go to bed with a headache, wake up with a headache. I unfortunately have had that a few times in my life doing really stressful things, and it's more of an annoyance than anything else. So hypersensitivity of pain fibers from the trigeminal nerve. I'm not sure that you really need to know that level of detail, but it does lead to muscular hypersensitivity. And so muscles, you have muscles that cover your scalp and your face and your neck, and they're all connected. And so if you start to get inflammation in some of those, then you're going to end up having pain and discomfort. Treatment for those usually is like ice, NSAIDs, maybe interventions to address muscular hypersensitivity. People like to get massages. People might do alternating heat with ice. Could be that you do stretches or exercises to help with that as well. Okay, migraines. So now we've moved from tension and cluster to migraine headaches. Migraines are very much, there's a wide range of migraines, but they do kind of fall into a clump of symptoms. An aura is usually a visual, sensory, or motor symptom that precedes a headache. So you may get flashing lights or little little sparks that you see. You might get kind of clouded or partial vision on one side. So the aura usually tells you that headache's coming. Now, auras are something else that you also can get in with seizures, where people have numbness, tingling, funny smell, a weird taste, maybe auditory or visual disturbances. So again, an aura is something that tends to be kind of particular to the person and tends to be sort of the same thing. So manifestations of migraines, again, it really depends on the person, but throbbing, unilateral or bilateral, moderate to severe pain, can often cause nausea and vomiting, photophobia, so photo, right, like picture, light sensitivity, phono, like phonograph, phonophobia is loud sounds, and then osmophobia, taste, smell abnormalities. You can have sleep disruption from these. People can literally wake up with a migraine, which is miserable. And the onset is that they're recurring. And then the question is how often they recur. So is this something that you get monthly, which means perhaps maybe it's due to something hormonal? Yeah, it just depends on the person. There can be a number of different triggers too, but for many young women, they will have a migraine during menstruation or just before. I can remember a period of time after I had my kids, so I guess it was in my mid to late 30s, and started having migraines, and they were always tied with my monthly cycle and would sort of declare the beginning of things. I'd wake up about 4 in the morning with a bad headache. But if I took the right medicine, then I often could go back to sleep and wake up at 6 or 7 for school or work and be fine and feel fine. So duration for migraines can be 4 to 72 hours per episode. And like I said, there's usually a prodrome. There's some some kind of activity that occurs before you even get the headache. So again, it could be a trigger, it could be maybe sleep deprivation, perhaps not eating for a while, something that sort of sets off the headache or sets you up for a headache. Then the aura, which sometimes you have an aura. Not everyone has auras, so it just depends. But auras are extremely common with migraines. And then you'll get the headache, part of it, and then a resolution, and then kind of recovery. And if any of you have ever had a migraine, even once it goes away, it kind of leaves you with this fuzzy, kind of out of it feeling, kind of wrung out feeling. I used to call it, like a migraine hangover, where the migraine's gone, but you still feel kind of wiped out from all of that. Patho for migraines, we don't really know. Could be genetic, environmental. Some people get migraines from triggers from things like, perfume and all kinds of weird things, lights. What's really interesting is people with migraines have an increased risk for epilepsy, depression, anxiety disorders, cerebrovascular disease, and cerebrovascular accident. So basically stroke. So for those of you who were in class, you heard me talk about my son who had lots of migraines starting from the age of 4 and then was diagnosed with epilepsy at the age of 25. He also has depression as well. And so, interesting, just kind of fits that profile. Current theories include neurologic, vascular, hormonal, and neurotransmitter, issues. And this proposed mechanisms, honestly, guys, don't need to know that. Episodes can be associated again with environmental triggers. A lot of times it can be things like weather, light, heat. Yeah, it's very interesting. So, but don't worry about the proposed mechanisms. Triggers. This is a really good one because knowing triggers is really helpful in terms of preventing headaches or minimizing them. So environmental factors, weather, altitude, time zone changes, again, sleep, which is on there. Foods that contain tyramine, and I don't care that you know that these contain tyramine, but look at the things that are on this list. These are kind of known offenders for migraine headaches. Aged cheese, red wine, nitrites, phenylethamine, monosodium glutamate, aspartame in diet drinks, sugar-free foods, caffeine. So I know for a fact that my son's headaches got markedly better when he cut out drinking Diet Coke. He used to be a Diet Coke drinker. And when he went in and was seen by the physician, they recommended that he cut that out. So what would be really smart is that somebody keeps a food diary and a headache diary. And so if you keep a headache diary along with foods that you're eating, you might be able to tie your headache to a food issue. So anxiety, stress, hormonal changes, hunger, strong smells, bright lights, things we've already talked about. So the treatment is avoid triggers. Okay, well, that sounds really easy, but it's not as easy as you would think. You can do TENS, which is this trans-electrical nerve stimulation. I would say that's not, at least has not been a huge treatment path in the past. Pharmacologic preventive measures actually have been used. Things like antihypertensives and estrogen. Actually, what's really been used quite a bit too are things like migraine and, sorry, not migraine, depression meds have been used pretty significantly to reduce migraine treatment. And then non-pharmacologic treatment are things like ice, a dark room, ensuring quiet, sleep. The treatment for migraines from a pharmacologic standpoint is NSAIDs, analgesics. I mean, you could look at Tylenol, you could try aspirin if that works. I would say that for many people with migraines, those basic over-the-counter meds don't work well. And so they end up going to something that's prescription. So ergot alkaloids are older drugs for migraines and may be effective for some people. That may be the thing they take. But nowadays, I think most people are taking triptans. So like sumatriptan, which is a selective 5-HT receptor agonist. Imitrex is the name that you know this drug by. And then, you can take antiemetics, which would be for the associated nausea and vomiting. For many people, a vomiting episode actually can relieve some of the pain of the headache, which is interesting. So again, this is sort of a repeat. Some people like this Excedrin migraine, which is a combination of aspirin, acetaminophen, and caffeine. Caffeine causes vasoconstriction. That's why if you've ever tried to cut caffeine out of your diet and you just go cold turkey and just cut it out, all of a sudden, if you notice, probably within a day or so, you'll have a whopping headache. And that headache will be from vasodilation. And it's because our bodies are used to getting caffeine every day and need it for vasoconstriction. So if we don't get it, then our bodies sort of say, oh, I'm not getting what I need for this. I'm going to vasodilate, and that's what causes pain. Moderate to severe pain, again, this ergotamine, tartrate, Ergomar, or like I said, the most common thing and most frequently used are the triptans, selective 5-HT receptor agonists. And I have to say, these have come out probably within the last 20 to maybe 20 years and really revolutionized the treatment of migraines. And then antiemetics. So let's talk more about these 5-HT receptor agonists, the meds that are used the most. So sumatriptan, Imitrex, is your prototype. And the bottom line with this is it causes intracranial vascular constriction. You have these 5-HT receptors in the peripheral nerves that innervate the intracranial vasculature. It's so weird. These 5-HT receptors, these suckers are all over the place. Like you have them in your stomach, you have them in your brain. But essentially, these receptors are responsible for intracranial vascular constriction. Well, if you think about what I said just a minute ago about how caffeine causes vasoconstriction, then you can see why these might work well. So these meds decrease the release of inflammatory neuropeptides, which decrease perivascular inflammation, and then again, this intracranial vascular constriction. Adverse effects are that it's generally well tolerated, although some people can have symptoms that are transient that can seem almost like the patient's having a heart attack, like some chest pain, maybe a little difficulty breathing, but it usually passes fairly quickly. The other symptoms that you can have is like heavy arms, chest pressure. People have said that after they've taken it that their skin, like on their face or their neck, feels tender, have almost like a pins and needles kind of feeling in their scalp. Not without touching, but when touched or, like standing in a shower, it can feel really strange. So patients should be forewarned of chest side effects. Just let them know that that could happen. But at the same time, don't give it to patients that are at risk for coronary artery disease, a history of MI, uncontrolled hypertension, TIAs, which are transient ischemic attacks, or strokes, because this does cause it causes vascular constriction. And even though it's primarily intracranial, we certainly would not want to trigger vasoconstriction in these other areas that may already be compromised. It is teratogenic, meaning that if it's taken during pregnancy, it can cause birth defects. So it needs to be avoided during pregnancy. And then patient teaching for intranasal and sub-Q administration. So if the patient needs to take Imitrex that way, they need to be taught how to do that. Many people start out with oral Imitrex and see how they do. And it should be taken at the onset of symptoms. The other thing about sumatriptan, and I don't know if you would put this under adverse effects or side effects, is some people actually feel something called the triptan rush. And it is a strange feeling. Again, it can be head, neck, chest, this kind of flushing or rushing feeling as this drug connects to these 5-HT receptors and activates this intracranial vascular constriction. So people can actually feel it. I personally have taken this drug a few times and have never felt that, but my husband, who took it quite a bit, felt it every single time he took it. So something else that you might want to prepare people for. Ergot Alkaloids, like I said, I can't remember where ergotamine comes from, but it's like a fungus. It's a strange thing to use for headaches, but it is used to stop migraine or cluster headaches. You really don't need to know the full mechanism of action. Just know that it's used for migraine or cluster headaches. Adverse effects for these patients is hepatic renal disease. Again, think about anything that if you have vasoconstriction, is going to cause a problem. So peripheral vascular disease, where you don't have good perfusion anyway, hepatic and renal disease, coronary artery disease, hypertension, sepsis, that's odd to me, pregnancy and lactation, and concurrent use of certain antifungals and antibiotics. So you want to be up to date on that. The thing about this is ergotamine makes you feel crappy. I mean, it might take your headache away, but it still usually makes people feel yucky. And so they'll oftentimes try to take other medications instead of ergot alkaloids. But for some people who've had migraines for a very long time and have figured out that this is what works for them, they're going to be unlikely to want to change. Again, this med, just like sumatriptan, should be taken at the onset of symptoms. And if the patient has muscle pain or weakness or changes in heart rate, that should be reported to the physician. There are a few foods that also increase its effect, like colas, coffee, tea, grapefruit juice. Okay, estrogen, estradiol. I guess I'll talk about it briefly. It is something that can be given prophylactically, so its prophylactic administration minimizes premenstrual decline in estrogen and prevents development of menstrual migraines during the late luteal phase of the menstrual cycle, which is just usually the day your bleeding starts. Adverse effects. So thromboembolic disorders. You guys need to highlight this circle this because it's very important to know that people taking estrogen, whether they're taking it in birth control pills, whether they're taking it in this patch for migraines, whether they're taking it for estrogen replacement post-menopause, which we don't really recommend anymore because it can cause breast cancer, but anybody taking exogenous estrogen is at risk for a clot, for a thromboembolic disorder. And even young women who may be on birth control pills primarily, or some implanted birth controls as well, may be at risk. And in fact, the other piece of this is if you're a smoker, a cigarette smoker, nowadays most physicians will not prescribe birth control pills to smokers because that combination of smoking and taking the estrogen in oral contraceptives increases the risk of stroke significantly enough that it's not worth the risk. Yeah, so that's what we're looking at. And then if you look at nursing considerations, it's a patch. You want to apply it to clean, dry skin, patient teaching, advise provider if there's breakthrough bleeding, or unexplained calf and chest pain. What are we talking about there? We're talking about a DVT or a pulmonary embolism. So again, you have to look at quality of life, how many days of work are missed. Giving a drug like this, comes with some risk. Okay, we're going to move on to seizures. Let me just say something before we start the seizures here. I would like you to know, tonic-clonic versus an absent seizure. But other than that, I am not going to get into complex or complex partial or generalized versus. That is very complicated and not something that you need to know really to understand the medications for seizures. One thing I will say though is you need to know what kind of seizure the patient's having in order to give the right pharmacotherapy. So the physician really needs to know what kind of seizure it is and preferably where the seizure is coming from. Then pharmacotherapy can really be tailored to the type of seizures that the patient has. But beyond that, I don't care that you know all the little details of different types of seizures. So let's just talk in generalities here. So a seizure is, in and of itself, is not really a specific disease. It's more of a manifestation. So something that happens, there can be a number of reasons for it. It's caused by a sudden transient disruption in cerebral electrical function and caused by this excessive discharge of cortical neurons. So these neurons are having like a little storm, which you can see really well in this photo. Convulsions or seizures themselves, you'll hear the word convulsion, refers to the jerky kind of contracting and relaxing tonic-clonic type movement that you'll see in a seizure. Epilepsy means that you have recurrent seizure activity. So one seizure does not equal epilepsy. 2, 3, 4 seizures is epilepsy. And usually there's no underlying correctable cause that can be found. And then we talked about this in class today too, is status epilepticus is continuous seizure activity lasting 30 minutes or more. And it's a medical emergency because you can lose your airway, not get enough oxygen, and in general be, seriously injured from just the consequences of having this long sustained seizure. The biggest risk is oxygen deprivation. So the pathophysiology, well, in general, this is what we're looking at. So we think that in people with epilepsy that there is some kind of what we call an epileptogenic focus. There's some spot in their brain that is susceptible to having a seizure if the seizure threshold is lowered. And the seizure threshold is sort of the conditions that make for a seizure to occur. So some medications lower the seizure threshold. Lack of sleep can lower a seizure threshold. Not taking one's medications on time can lower the seizure threshold. So that threshold is sort of the point at which, the patient's going to have a seizure. So this epileptogenic focus fires more frequently with greater amplitude, and you end up getting these tonic-clonic seizures. Again, these definitions in here, like bullet point 4 and 5, you don't need to know that tonic phase is associated with loss of consciousness, and clonic, you don't need to know that. So the seizure discharge is interrupted, though. The electrical impulse is interrupted, which can cause intermittent muscle contractions. So that's why you'll see someone will begin to have a seizure, begin to shake, maybe arms are moving, they're, doing some kind of often rhythmic movement, and then you'll see them begin to slow down. That movement will begin to slow in frequency and then will eventually stop. So again, at the bottom here, this last bullet point, critical to know. Oxygen consumption during seizure is high, and potential for progressive brain injury and irreversible damage is there if seizure activity is continual and severe. And remember, I told you the story about my friend's little girl, Sarah, who had seizures that developed while they were out camping in the desert outside of San Diego. And she ended up having status epilepticus and is now confined to a wheelchair, nonverbal. Really have no idea what the underlying pathophysiology of that was for her either. So in terms of seizures, we know that in younger children, growing brains, exposure to fever, other things like that, those are common. It's common for kids to have a seizure. I know that sounds crazy, but more people have seizures than you would imagine. But again, one seizure does not equal epilepsy. So in young adults, ages 18 to 35, and this is where my son fits in, is alcohol withdrawal, brain tumor, idiopathic, meaning we have no idea what the cause is, illicit drug use, post-traumatic brain injury, and perinatal insults. So those are some of the probable causes. In older adults, it tends to be things, again, idiopathic brain tumors are still possible. Not brain tumors. Seizures are still possible, but we tend to have more seizures as over the age of 35 related to a specific issue, like alcohol or drug withdrawal, a brain tumor, a stroke, aneurysm, infection, degenerative disease like Alzheimer's, something like that, and then metabolic disorders. So uremia, hepatic failure. Remember, in hepatic failure, what gets really high is your ammonia, and you can have hepatic encephalopathy that could lead to a seizure. Electrolyte abnormalities, I'm specifically thinking of like Hyponatremia tends to be a big cause of seizures, and hypoglycemia, and then post-traumatic brain injury. So perhaps after a motor vehicle accident or something along those lines. Okay, threshold for seizures can be lowered by, you should know this list: hypoglycemia, lack of sleep, emotional or physical stress, a febrile illness. Now, febrile illness is pretty much related to children, and I would say children under the age of 10. When we see what we call febrile seizures in children, it's due to this rapid change in temperature that occurs in little kids, where they go from being, a normal temperature to 103 in like 30 minutes. Brains don't like that very much, and some children just seem to be prone to seizures related to a fever. In children who have that, or if there's been a family history of it, these are kids that when they feel warm should get Tylenol or an antipyretic and anti-fever medication right away. Better for those kids to give that medication early than to wait for a fever to really declare itself. Hyperventilation, so respiratory alkalosis, can lead to seizures. So again, this could happen in an ICU setting where a patient's on a ventilator and the patient becomes overventilated. So again, it requires lots of close watching from the medical team. And then environmental stimuli, and like we said, menses. And again, don't worry about the classifications of seizures. So again, I'm just going to talk about absence seizures versus like atonic-clonic. Don't get into all of these terms, myoclonic. We can talk a little bit about atonic because they're really interesting. But in general, an absence seizure is like a stare. Can look like a long stare that seems to last just a little too long. Unresponsiveness, but then it's sort of like somebody who answers you slowly, but sort of looks at you and considers what they're saying, but maybe just a little too long. So it can be hard to diagnose. So that's an absence seizure. An atonic seizure is just total loss of all muscle tone, and it's called a drop attack. So A meaning without, and tonic, tone, right? So without tone, people just fall to the floor. Those are much less common. And then the one that we tend to think of and see on TV and is the tonic-clonic, which is the rhythmic contraction and relaxation of muscles. Sometimes we call this a grand mal seizure. Again, partial seizures versus, I'm not worried about that, to be honest with you. There are a number of seizures, like I said, where patients do not lose consciousness, but where they sort of lose ability to speak or have some other kind of, outward manifestation, but they don't lose consciousness. And then there are some where you do lose consciousness. Okay, seizure phases. I think the important thing here is to really say there's 3 phases: pre-seizure, during the seizure, and post-seizure. Okay, so just take ictal and turn that into seizure, and you're good to go. So pre-seizure, again, you may have this prodrome. We talked a little about it. Malaise, headache, sense of depression. Hard to tie that to a seizure coming on, but in retrospect, after the seizure, a lot of times we can look back and go, oh yeah, I get it now. And then an aura is a particular or peculiar sensation preceding the onset of a generalized seizure, usually within minutes of the seizure occurring. The ictal phase is when the patient is actually having the seizure, and whether it's tonic, clonic, doesn't really matter. They may or may not be incontinent. during the seizure. And then you have the post-seizure phase, post-ictal, is the period following seizure activity. And like I said, headache, confusion, dysphagia, memory loss, paralysis, fatigue, sleepiness. What I saw mostly with my son was headache, fatigue, sleepiness, and definitely memory loss. For a few hours after seizure, if you talk to him about anything, he doesn't remember any of that later. So diagnosis and treatment, well, we want to know why they're having a seizure. So we do some basic things to try to figure it out. You'll do history and physical, lab tests, look at their, blood and their urine. You may do a spinal tap if you think there's some reason to do that. You do brain imaging like a CT of the brain or an MRI, and then an EEG. Here's the thing about an EEG. EEG oftentimes does not pick up anything in people who have seizures if they're not having a seizure. So if they're not having a seizure at the time the EEG is done, it's not always helpful, because when you're not having a seizure, your brain's in this normal state. It may look very normal on an EEG. Now, sometimes, even in a normal state, the docs will be able to pick up kind of an interesting wave on that EEG, an interesting tracing that says, here we go. Here's some interesting things that are happening. But more often than not, the EEG is normal. So doing an EEG after someone's had a seizure and they're recovered, if they go into the emergency room, a lot of times it's not going to tell anything. The treatment is really to address the underlying cause, which is fine if you can identify a cause, but if you can't, that can become very frustrating. Non-pharmacologic treatment is ketogenic diet. Now, a ketogenic diet is a diet that's high in fat and protein and has very low or no carbohydrates. Fat is really the key in this diet. And I will tell you that there is lots of evidence, research evidence, to show that ketogenic diets are extremely helpful, especially in children with seizures. So it's something to consider. And the only thing is a ketogenic diet can be very difficult to maintain. But, if you're a young kid and you have lots of seizures and your parents are controlling your food, that might be an option. And then pharmacologic treatment, actually, some kind of a medication to treat seizures. So there's a couple of different classes of meds here that we're going to look at for pharmacologic treatment. Benzodiazepines. These are probably the drugs that you need to know. They're probably the most important that you need to know for seizures, because they're given to stop a seizure, especially status epilepticus. And so the benzodiazepines are I see there's a typo in here too, benzodiazepines. So if you think about benzos, you're thinking of all of your azapram drugs, right? Like diazepam, lorazepam, all of those, clonazepam. So those are great drugs, but they can cause respiratory suppression, especially if taken with other CNS depressants. Honestly, when somebody has status epilepticus or a seizure, it's not that we're not worried about their respiratory status, because we are. We definitely are. Seizures take up lots of oxygen from the brain, which could cause us to not breathe well. But what we're really interested in is stopping the seizure. So if we have to, we'll stop the seizure and support the patient, from a respiratory standpoint by putting them on a ventilator if we have to. But these are the drugs that we use, and they inhibit the effects of GABA, which is GABA aminobutyric acid, I believe. So there's some considerations. There is a reversal agent for benzodiazepine intoxication. It's flumazenil. Honestly, I don't care if you know that for this particular lecture because we've already talked about benzos in other ways for other things. But, this is where we take a really common drug that's used for anxiety and sedation, and use it for seizures. Also, then, the big question is, how do we prevent seizures long term? So patients usually go on some kind of an anticonvulsant medication, and the goal is to bring seizures under control with the least possible disruption in lifestyle and minimum side effects. Lots of these drugs have a lot of side effects. But if you think about the impact of a seizure disorder on someone's life, if you have seizures and you're not able to control them with medications, it has a significant impact on a person's life. You can't drive. If you're a parent of young children, you can't be left alone with them, right? What if you have a seizure and you're in charge? You're in charge of the baby. So it really is in the patient's best interest to work hard to find a medication or a set of medications that work to treat seizures. Looks like they're sort of throwing anticonvulsants into a big pot here and just talking about them in general. And that's fine. I'd rather that you know more sort of nursing considerations. Anybody taking anticonvulsants on a regular basis will have ongoing and regular liver renal function tests and blood serum levels, depending on the drug. Some drugs actually have a therapeutic dose, and so you need to measure that with a blood level. But I know my son, who takes 2 medications every day, gets liver and renal function tests probably every 3 months. So you just monitor for complications. You want to be careful about the other medications that patient may be taking along with anticonvulsants, and then monitor for signs of medication toxicity, things like depression, ataxia, remember that's difficulty walking, nausea, vomiting, drowsiness, dizziness, restlessness, visual disturbances. And then evaluate for therapeutic effect, which is there decreased seizure activity, right? And provide patient education about the meds. So patient education, let's hit the big stuff. That is a great picture of gums related to phenytoin or dilantin. Phenytoin causes gingival hyperplasia, which is what you're seeing on here, and it's totally due to the drug. So you have to really, really watch their teeth. Okay, so patient education. Bottom line is compliance is key. Key. So you definitely have to take the meds at the same time, every day, the right dose. Do not discontinue the medications abruptly. Take them with food. Be aware of the side effects. Caution when driving, avoiding alcohol, sleep agents, over-the-counter meds. Patients who have seizures, ongoing seizures or epilepsy should have a medical alert bracelet or necklace or some kind of identifier. My son wears a medical alert bracelet. It doesn't look like that, but any EMT who's looking for it will find it. And if you look on the inside of it, it'll tell you that he has epilepsy and tells you that he's also allergic to peanuts just for kicks. It's like, well, we have to wear this thing, might as well wear it. Use 2 types of contraception if you're sexually active and of childbearing age. That is for the female. And blood tests we talked about. And if there's extended release capsules, do not crush, chew, or cut them. Just, you guys already know that. Okay. And then of these 3 drugs, phenytoin, which is also known as Dilantin, again, maintain good oral hygiene. And this gingival hyperplasia is like a classic, kind of a classic drug sign of drug side effects of Dilantin. Carbamazepine, symptoms of bleeding or bruising, and then valproic acid or valproate, symptoms of pancreatitis. Okay, on to meningitis. So meningitis, so you guys learned about the meninges, and you've learned about itis. Itis is inflammation, so this is an inflammation of the meninges covering the brain. There's multiple causes, bacteria, fungus, fungi, viruses, parasites, toxins. Fungal meningitis is very rare, still possible, but rare. Viral meningitis does occur, is probably less rare than fungal, but it's also less severe. Viral meningitis can make the patient, feel yucky, but usually has less consequences, sequelae for the patient. The bad one is bacterial meningitis. It tends to occur in places where people are congregated, like dormitories, military bases, homeless shelters. It's spread by respiratory droplets and contact with contaminated saliva. So it's droplet precautions, you guys, if you're in the hospital. Droplet precautions. It's not airborne, it's droplet. It's the actual secretions. And the causes of it are multiple, but they gave you a couple of examples here, like Haemophilus influenza type B. Now, kids get Haemophilus influenza type B, Hib. They get the Hib vaccine. They get a couple of times when they're in that vaccine heavy stage between the ages of 0 and 12. Streptococcal pneumoniae and Neisseria meningitis. So just those are the most common. And then risk factors is anything that introduces bacteria into the body, like head trauma, a fracture, severe sinusitis, right? Your sinuses are sitting right next to your brain. Someone who's immunocompromised is at risk for meningitis. You know who we often see meningitis in? A lot of times viral, sometimes bacterial, and I would say not always, but usually pretty good prognosis is babies. We see it in babies, and it's before they can get their Hib vaccine, and they come in with a fever, and we sometimes find meningitis, and we treat it with antibiotics, and they do well. It's if it's left untreated where we have problems. So pathophys, meningococci and pneumococci are inhaled, and they cross the mucosal barrier in the nose and get into the bloodstream across the BBB and get into the brain. And bacterial toxins from those bacteria cause cerebral edema. Then our friends neutrophils enter the subarachnoid space and release inflammatory cytokines and exudate, which thickens the CSF and obstructs CSF blood flow. It's like pus in the brain, basically. And together that increases intracranial pressure. So now you have a brain that's too swollen inside of a fixed, hard skull, and this starts to cause problems. Some of the manifestations that you can see, infectious signs are things like fever, tachycardia, chills, Meningeal signs, these are things related to those swollen meninges, are severe headache, photophobia, so absolutely cannot tolerate any light coming in the eyes, nuchal rigidity, which is rigidity of the neck, and then positive Kernig and Brudzinski signs, and you can see those down here at the bottom. I think the important thing to remember about these two signs is that it's a positive sign that means that they have meningitis. I get confused with the two of these, Kernig and Brudzinski. Actually, Brudzinski's used more in children, so I know that a little bit better. And then neurologic signs of meningitis can be things like decreased level of consciousness, delirium, unconscious, seizures. Seizures actually can be common with meningitis. And then as kids or people get really, really sick, you will see purpura and petechiae, which we've already talked about a little bit. And this is the body's way of trying to wall off this bacteria by sending platelets and other clotting factors to surround and kind of wall off this bacteria. And the problem is that eventually, in that clotting attempt, the attempt to sort of clot everything off, wall everything off, the body runs out of clotting factors and platelets, and this causes hemorrhages into the skin. And purpura is just these large areas of hemorrhage. Petechiae are like little tiny dots, little pinpoint dots of bleeding. Like I would say down on the toes in this picture, those are more petechiae, but purpura is this big sort of swath of bleeding and bruising. The treatments, if it's bacterial, then you want to get the right antibiotics on board. Otherwise, it's usually just supportive therapy. Transmission-based precautions. So again, droplet precautions. Antipyretics, because of fever is also going to increase intracranial pressure and pain. So keeping their temperature down. Giving them anti-seizure medications. Doing good neurologic assessments. There are other things you can do to decrease intracranial pressure, shunts, and other things, but that's for another conversation. And then prevention of meningitis is vaccination for at-risk groups. We've talked about this a lot. In fact, I think a fair number of people missed this on our last test. So again, meningococcal, pneumococcal, and Hib. Meningococcal should be given at age 12 as a booster or as a shot, and it should be given again right before you go to college. So if you guys have not had a meningococcal vaccine in the last, 5 years or 6 years, you might just want to look that up and check it out. You can look it up on the CDC website to see how often you should be getting that. And then pneumococcal as well. That is it. I hope that's helpful, guys. Medication lecture is coming as well. And yeah, thanks for your attention.